Hi, good evening, everybody. Welcome to the SADA webinar this evening. We just want to thank Colgate this evening, who is our trade partner for SADA Oral Health Month, who's sponsoring this event tonight. We also want to thank SASPIO, who is the South African Society for Periodontology, Implantology and Oral Medicine, who's also co-hosting this evening with us tonight. And with that, we've got Dr. Johan Lochner as a panelist this evening with us. Welcome, Dr. Lochner. Just as a reminder to everybody, while we wait for all our attendees to join, we're up to, I think, about 230 odd at the moment. I think there's about more than 500 joining. Please refrain from using your raised hand function on the Zoom platform this evening. Please make use of the Q&A section at the bottom of the screen for any questions that you might have. The Q&A section will follow the presentation at the end of the evening. Your CPD certificates will be, a confirmation of that will be emailed to you. You will get one CEU, clinical CEU for this evening. Bear in mind that for the points to actually be loaded onto your SADA profile will take some time. Please do not worry if it's not happening within the next week or two. It will happen as long as you receive an email from SADA within the next couple of days to confirm your attendance of this evening tonight. We are also streaming live on YouTube, so welcome to our YouTube viewers this evening. And then right at the end of this evening, after the webinar has closed and the Zoom function is closed, you will a survey will pop up on your web browser. Please stay online for that, and please complete the survey first at the end of the webinar this evening. We also just want to confirm or announce some upcoming events or webinars coming up on the 22nd of September. We have a lecture by Dr. Anthea Jefta on periodontitis and diabetes. That's on the 22nd of September. And on the 29th of September, we have Dr. Shumani Manenze on the diagnostic approach to oral mucosal lesions. So please register for those events on the SADA website. Let's see how much attendees we've got at the moment, about 270. I just want to repeat some of the comments that I made at the beginning. Please refrain from using the raise hand function. Please make use of the Q&A section at the bottom of your screen. And please stay online at the end of the webinar to complete a survey that will pop up on your web browser. Right, I think that's about all the introductions that I need to make. I'm going to hand over to Dr. Johan Lochner this evening. Welcome, Dr. Lochner, who will introduce our speaker and host the rest of the evening. Thank you, Dr. Lochner.
Thank you, Renier. Good evening, everyone, and very welcome to this SADA webinar. I'm Dr. Johan Lochner. I'm practicing as a specialist in oral medicine and periodontics in Somerset West, here in the Western Cape. But tonight I'm privileged to announce our speaker. Her name is Dr. Sibongile Mahlangu. She is from the Witbank area up north, and she attended secondary school Greenfield, so I'm sure there's a lot of you that might know her. She graduated as a dentist from University of Western Cape, worked in private practice, and also at the University of Witwatersrand, where she obtained an MSc. And she's currently a registrar at the University of Western Cape in oral medicine and periodontics. So with that introduction, I would like Bongi to take the screen or the floor, and we look forward to your presentation.
Okay. Thank you there. Good evening, everyone. I'd like to firstly maybe start off by thanking SADA as well as SASPIO for the opportunity. And thank you, Dr. Lochner, for the introduction there. I was asked to share a case that I got to see in one of our clinics. So as already introduced, I am a registrar in the University of the Western Cape. And so we do rotations in 3 different hospitals. This is Tygerberg, Mitchell's Plain, as well as Grooteskier. And this, the patient that I'll be presenting today, I got to see in the in the Tygerberg Oral Med Clinic. So these are the learning objectives, and they include the clinical presentation of syphilis, the management of syphilis, as well as the multidisciplinary approach to managing patients with syphilis, and then the management, the disciplines that are involved in the management of syphilis. We'll also be looking at the ethical duty that we have towards minors who present with sexually transmitted diseases or infections. I will look at the current legal situation with regards to obtaining consent, delivering results to patients, as well as the doctor-patient confidentiality. And we'll also look at the ethical obligation and protocol toward a patient who is a minor. So just a introduction, and this is mainly a refresher on syphilis. So we know that syphilis is a chronic bacterial infection. It is caused by Treponema pallidum, which is a bacteria, and falling under the species pallidum. And its primary mode of transmission is sexual contact and mother to fetus. And it is most commonly seen, syphilis is most commonly seen in areas of countries of low income and middle income. So the incidence of syphilis, as well as other sexually transmitted infections, has been increasing, and this is seen with the HIV infection. So I just want to, okay. So in terms of the epidemiology, when looking at syphilis worldwide, there was more than 5 million new cases of syphilis yearly, most infections occurring in the low and middle income countries. And there's a current resurgence, and this is attributed to changing risk behaviors, and it's also closely linked with HIV infection. When we're looking at the global incidence of syphilis, or rather sexually transmitted infections, in 2012, there was 357 million new cases that were seen, of which in Africa, 63 million cases made up that total. And then when we look at the prevalence of STIs in 2017, looking at South Africa now, there was 2.3 million cases of gonorrhea, 1.9 new cases of chlamydia, and 23,175 cases of syphilis. And then, so I just brought in the global vision and goal, as well as the target with regards to sexually transmitted infections. And so the main goal rather is to end the sexually transmitted infection epidemics as major public health concerns. And the target is to have 90% reduction of the STIs, and mainly focusing on Treponema pallidum, gonorrhea, as well as chlamydia. And I brought this in because it, in a way, links in with the global target or vision with regards to HIV infection. And we know that with that, there is that 90-90-90 goal, of which the 90%, it's to first initially get 90% of people who are infected with HIV to know their status. And out of that 90% of cases, to have them on treatment or ARV treatment, and to have that 90% on ARV treatment to have a viral load that is low or undetectable. And so when we look at now the HIV infection, as it was reported on in 2018, there has been a decrease in the number of new infections across the world. And when we look at South Africa, we're looking at 7.5 million people that are living with HIV, of which 19% are adults or between the ages of 15 to 49. So syphilis, and when we look at syphilis and HIV, so with STIs, there's an increase, while with HIV, we are seeing a decrease globally. But STIs increase the risk of HIV infection and transmission. In 2014, in the USA, 40% of individuals diagnosed with early syphilis were infected with HIV at the time of diagnosis. 3.5 to 4% of those who were HIV negative at the time of the STI infection became infected with HIV in the year after diagnosis. So this is one of those, one of the articles that I could find that was speaking to the increased risk of HIV infection in patients with STIs. So syphilis remains a concern because the primary syphilis significantly increases the risk of transmitting and contracting HIV infection, and HIV may advance the natural cause of syphilis, in particular neurosyphilis. So going back to syphilis, the infection undergoes evolution through 3 stages, namely the primary, secondary, and tertiary stages. And patients are highly infectious they are highly infectious in the primary and secondary stages. And pregnant women can transmit the infection during the latent phase or during latency. So we'll look at the different stages and they are how they manifest. So with primary stage, the onset is 2 to 3 weeks after inoculation, and the lesion is called a chancre, which is actually characterizing primary stage, and it is seen at the site of inoculation. It presents as an ulcer that has a thin base and it's indurated, and these ulcers are said to be painless. And during this phase, the organism does spread via the lymphatic system. And so patients do present with regional lymphadenopathy. So the most common sites for the lesions are the genital, in and near the rectum, the upper lip in males, the lower lip in females, buccal mucosa, palate, tongue, gingiva, and tonsils. So it's important to note that these lesions can resolve without treatment. So they can resolve spontaneously 3 to 6 weeks after their initial presentation. So the next stage would be the secondary stage, of which the onset is 4 to 10 weeks after the initial infection. And it is said that the clinical presentation or the clinical occurrence of the lesion can be at the time when the patient still has a chancre or the primary stage lesion. So these can occur concurrently, or it can be after resolution of the secondary stage. So the clinical presentation is the mucus patches that can be seen on the palate, as well as sometimes on the buccal mucosa. So the mucus patches can coalesce or fuse, and they form the snail track pattern. And the other presentation is also the condyloma lata, which are actually nodules that are papillary that can be seen. And these are most commonly seen on the tongue. So on the left, we can see the mucus patches, and then on the right, we can see the condyloma lata. So in terms of the systemic presentation, the patient can present with malaise, sore throat, headache, low-grade fever, diffuse lymphadenopathy, maculopapular cutaneous rash that is seen on the palms and plantars. So resolution is seen 3 to 12 weeks after the clinical presentation. When we look at the tertiary stage, so the onset can be periods of years to decades, and the clinical presentation is a gamma, which can present as a perforation on the palate, and this perforation would then cause a communication between the nose and the oral cavity. So the common sites for this lesion is the tongue and palate. So on the tongue, it would also present as a lobulated area that can be seen. So that it's important also to maybe mention that patients can undergo latency, which can last 1 to 30 years. So I'll just introduce the case. So this was actually a 18-year-old patient that presented at Tigerberg at the oral medicine clinic. The patient presented with her mother. So she came in, brought in by the mother. And the main complaint was that there's a growth on my tongue. And when we were going through the history, the growth started as a pimple. And this was 4 months prior to me seeing the patient. So it was not painful. The pain only started when she was later. So it was not on the initial presentation. And the pain that she was feeling was only with food. And she was also mentioning pain on the throat and on the tongue. And she had also she was also presenting with cramping and nausea. And this started a week prior to consultation. And then in terms of the medical history, the patient does suffer from sinusitis. She uses over-the-counter medication. She was using ibuprofen and paracetamol and Dynexen for the pain. And this was over-the-counter as well. So Dynexen she was applying on the lesions, especially prior to eating. And in terms of the social history, she started smoking at the age of 16, and she smokes 2 cigarettes per day. She does not consume alcohol. And we did ask the patient. Now, maybe it's important to just mention that we did ask the mother to leave the consultation room so that we could be able to extract as much information from the patient as possible. And as we know, this makes the patients, especially if it's a younger patient being accompanied by a parent, it makes them more comfortable to share or to be honest with us. So we did ask the patient with regards to whether she is sexually active, of which at this she said she was not. In terms of the extraoral examination, so there was right submandibular lymphadenopathy. The TMJ, there were no abnormalities detected. The extraoral lesions, we did ask of this if she does have lesions elsewhere in the body, and she mentioned the anal area and the genital area as well. So in terms of the panoramic view, we can see the patient does have teeth that were extracted, a tooth that was extracted rather. She does have roots and a periapical area on the 4-6 area. There is crowding that is seen on the upper anterior. And when we look at the clinical pictures, we can see the root, the 4-6, the missing 3-6, the retained primary tooth in the first quadrant, and that canine that is erupted. And then when looking at the lesions, starting off with the lesion that is in the center, we can see the mucus patches that are characteristic of the secondary stage of syphilis. So they do coalesce and they form the snail track pattern. And then on the tongue, maybe going systematically, when you're looking at the tongue, on the dorsal surface of the tongue, as well as the lateral aspect of the tongue, both left and right, but more on they're most severe on the right than on the left. The anterior, the tip of the tongue, where it is actually extending or to the ventral surface of the tongue, as well as on the top right picture here, where we can see that the lesions on the lateral aspect of the tongue or the lateral borders of the tongue are actually extending towards the ventral surface. And these are the papillary nodules that we see. We can see that in certain areas they lobulated, and these are called the condyloma lata, which are also characteristic of secondary stage. So when we are in the clinic and we are going through the differential diagnosis, what does assist is the surgical sieve, and we categorize we put the differential diagnosis in different categories, and mainly looking at hereditary, reactive, infective, and under-infective. We have viral, fungal, and bacterial. Immunological, of which that also includes the autoimmune conditions, vascular, neurologic, metabolic, and neoplastic. So this assists us in not just, like looking at a lesion in isolation, but thinking more broadly. And so we go systematically. And so with regards to the case that presented, the categories that we chose were mainly infective and metabolic. And under infective, we had bacterial, which is syphilis and TB. And then under fungal, we had deep fungal infection. Under metabolic, we had Crohn's disease. And we included this because of the symptoms that she also presented with, the cramping that she was presenting with. In terms of the investigation, so we'll go through the different serologic tests that can be performed with syphilis. So there's non-treponemal tests as well as treponemal tests. And under non-treponemal tests, we have the RPR, which is rapid plasma reagent test, as well as the venereal disease research laboratory test. So these tests detect non-treponemal antibodies, and these would be antibodies that are produced by the host in response to cardiolipin as well as lipolipin, lipoidal material that would be coming from the host cells that are destroyed. So cardiolipin is of importance because some of it is also produced by the spirochetes. And then this test is also used to monitor the status of infection. So you are able to see whether the patient has an active infection or the patient is in latency. And then when we're looking at the treponemal tests, these detect the Treponema pallidum in all stages of infection. So they confirm the presence of treponemal infection. So under these, the examples are Treponema pallidum particle agglutination assay, Treponemal pallidum hemagglutination assay, fluorescent treponemal antibody adsorbed test, microhemagglutination assay for antibody to Treponema pallidum. And it's important to note now that we need both tests, both the non-treponemal and the treponemal tests. So when we're looking at the different stages and now linking in the tests, we can see that with your non-treponemal tests, the RPR and VDRL, these are highly sensitive from day 6 of infection. So the primary stages, secondary stages, and tertiary stages, these are highly sensitive. While your treponemal tests, mainly the FTA ABS, is highly sensitive from primary to secondary, secondary, and tertiary stages, while TPPA and TPHA are highly sensitive during the secondary and tertiary stage. All right, so when we look at the traditional algorithm with regards to syphilis and testing or screening, we start off with the non-treponemal test, which is RPR. So just maybe to go back, the VDRL is mainly used with patients that are presenting with neurosyphilis. So it's mainly used to test CSF or cerebrospinal fluid. So going back now to the traditional algorithm, we start off with the non-treponemal test. So that would be the RPR. And then from there, if it is positive, then the treponemal test is done, which is TPPA, or it can be the other test. And this would then confirm if there is syphilis, or rather if there is treponema in the serum. So the important thing here is that you cannot rely on one test to confirm for syphilis infection. So in our case, the investigations that were done under serology, we have full blood count and the differential count. Under immunology, we had syphilis serology, and under virology, we had HIV serology, which was an ELISA, not a rapid test. And the importance here is that we already had an STI as part of the differential diagnosis. So we need to also screen the patient or rule out a co-infection with HIV. And that's why we had to include that. And then we did a biopsy. And this was an incisional biopsy on 2 sites. So we remember that with the presentation, there's lesions, there are lesions that are presenting differently. So the condyloma lata, as well as the mucus patches. So we took, I took a biopsy from the retromolar area as well as the tongue. So when we're looking at the results, the hematology, so when we're looking at the full blood count, though the levels are said to be low, if you look at the range, they're still within, they're not far off from the range, and so it is not of concern. When we look at the differential count, we can see that the eosinophils are high, and this is attributed to her medical history of sinusitis that she alluded to. And then when we look at the immunology, so the RPR as well as the T pallidum antibodies, this came back as reactive. And what is important with the RPR is to look at the titer, and the titer was high. So the titer would then be used to also, so RPR is used as a screening tool as well as a tool to assist in terms of management of the patient. So meaning that when the patient is followed up, the titer is rechecked, so you can't do the RPR. So you want to see a decrease rather than an increase. So then you know whether you need to retreat the patient, or then there's a need for change in medication, etc. So remembering the RPR tells us whether there's active infection or latency. And then in terms of the HIV screening, that came back as negative or non-reactive. And then when we're looking at the histopath results, the diagnosis came back as Treponema pallidum infection with concomitant candida infection. So there was a superinfection, which is candidiasis. We'll go through the histopath pictures as well as what they mean. So in this picture, this is to show the pseudoepitheliomatous hyperplasia that is seen in lesions that are associated with syphilis. In this picture on the left, we can see that there's neutrophil exocytosis. And the picture on the right depicts this dense lymphoplasmacytic infiltrate that is actually characteristic in syphilis. And then looking at the endothelial swelling, as well as the perivascular as well as the perineural lymphoplasmacytic infiltrate that is seen. Okay. The special stains that were performed. So this included the periodic acid shift because of the concomitant candida infection that was seen on the other slides. So the periodic acid shift would be to outline the presence of hyphae. The Wharton study was used to outline the corkscrew, which is the spirochete, the shape of that spirochete, and we can see them depicted on the slide on the right. And then in terms of immunohistochemistry, we can see there is intraepithelial as well as a lamina propria presence of T. pallidum. So when we're looking at the management of these patients, so I did a flow diagram. So we start off with the examination of the patient, and then we can perform a biopsy and do serology investigation. And then under serology, you would also include the HIV testing. And then it is important to communicate the results, the risk and management with the patient. And this also includes education, educating the patient about the disease, about the infection, and the need for their partner to also get screened and managed. And then the next step would be to refer the patient to infectious disease or to a medical practitioner. So we are at an advantage in that we are in a tertiary institution. We do have these other disciplines that we can refer the patients to. So with regards to my patient, we did speak to the patient. I did speak to the patient and offer, because you need to also find out from the patient whether they are comfortable being seen in that particular area. So I did explain to the patient what their management entailed, and that we need to refer to infectious disease. And she declined the offer, of which now we were left with the option of referring the patient to a local clinic or to a medical practitioner, of which we needed to just write a referral for the patient instead of communicating with infectious disease and the patient just going within, the premises. And so the patient did go to a private medical practitioner, and this, like I could see the association with the stigma that comes with the infection, not wanting the mother, first of all, to know her results, and not wanting the community that she stays in to actually know of her infection. And then it is important also to follow up with these patients. So with management, early syphilis, the management for early syphilis entails the benzathine benzyl penicillin, which is 2.4 units intramuscular as a single dose. And for those patients that have an allergy to penicillin, they can be given doxycycline or tetracycline. And benzathine is said to form a depot from which this benzyl penicillin is then released, and it would bind to a protein inside the cell wall of the bacteria and inhibit cell synthesis. And then this would then cause the lysis of the cell. And then with regards to late syphilis, it's 2.4 million penicillin intramuscularly weekly for 3 consecutive weeks. And in terms of the penicillin allergy, it's doxycycline 100 milligram twice a day for 28 days, or tetracycline 500 milligram 4 times daily for 28 days. And for women that are pregnant that are allergic to penicillin, they're desensitized and they follow this same regimen as late syphilis. So we'll look at ethics. So I included this part because we were faced with a different scenario, a completely different scenario. First of all, the patient came in with a mother. So it was easy to actually ask the mother to step out while we speak to the patient, getting the medical history, etc. But now the mother is the one who actually brings in the daughter for the results, etc., and for management. So now having to go through literature to actually see where do we stand in terms of ethics when it comes to revealing the results or sharing the results with the patient. And so I decided to put in ethics as well in this presentation. So in general, any information that is given in the context of a professional relationship with a patient is bound by the ethical duty of confidentiality. And this is according to the National Health Act number 61 of 2003. The information that is provided by the patient is used only for the purposes for which it is given. Confidentiality is a way of respecting the patient's autonomy. And one of the things that we should remember is that the patient's information belongs to the patient. And so we need to get authorization before we can actually disclose information. So the unauthorized disclosure of information may cause harm, and this is psychological harm, and that is sufficient to establish a breach of the duty of confidentiality. So healthcare workers or healthcare practitioners should treat personal or private information as confidential in professional relationships with patients unless overriding reasons confer a moral or legal right to disclosure. And then in terms of autonomy, healthcare practitioners should honor the right of patients to self-determination or to make their own informed choices and to live their lives by their own beliefs, values, and preferences. When we look at decisional capacity and the definition, it is the capacity to make decisions in light of information about the relevant risks, benefits, and consequences of the proposed intervention. And so I included here the age of consent. So the age of consent to sexual intercourse is 16 years. And this is according to the sections that are listed on the right. And the age of consent for an HIV test is 12 years. But in literature, it says that a younger child with sufficient maturity, and this is referring to this decisional capacity, they can still consent for an HIV test. And then the age of consent to medical treatment is 12 years, and the age of consent for to surgical treatment is also 12 years. So I put this in here because one of the things that we had to address with a patient is that when we were extracting information on that initial visit, we did ask the patient if she is sexually active, of which the answer was no. And so with delivering the results, part of our duty is to find out if the patient might have been raped or is being sexually abused before, like we move on straight to the patient having a sexual partner. And so we did discuss with the patient, and we did ask the patient to be as honest with us as possible. And on that day, the patient did mention that she does have a partner, and it's only one partner, so she was having consensual sex. And then, so when we're looking at the exception to maintaining confidentiality according to the National Health Act number 61 of 2003, chapter 2, section 14. So these would be instances where we can actually disclose information of the patient. This is if the patient consents to the disclosure in writing, the court order or any law requires the disclosure, non-disclosure of the information represents a serious threat to public health. So it may be justified to make confidential information known without consent if the life of the third party is at risk, the patient consents to the breach in confidentiality, when you as the practitioner, you are ordered to divulge information in a court of law, when compelled to breach confidentiality by an act of parliament, and this is seen in cases of child abuse, or when a healthcare practitioner is a defendant or an accused, and when pertaining to information that is material to the case against the practitioner. And when there is a moral or legal obligation on the practitioner to make a disclosure to a person who has a reciprocal moral or legal obligation to receive that information. So in conclusion, this for me was really a case that stood out in 2019 because I did my undergrad at UWC. I saw STIs on a textbook. So it was mainly theory. And in 2019, I got to see the first case, my first case of an STI. So it stood out in that, like I could now relate to what I have learned back then. And we needed a refresher also in the clinic. And it was really an exciting journey. So syphilis, why is it important for us to know of STIs or to even go through this presentation? It is because syphilis compromises the quality of life, and it also facilitates the transmission of HIV, of which I did say that, with regards to the global goal, when we're looking at HIV, it would impact that because we're seeing a decrease in HIV infection, but with the increase of the other STIs, we will then see an increase in HIV in future. So we need to actually now also go back to education in terms of STIs with our patients. And then when we're looking at confidentiality and consent, this was very important in this case, because though the patient is seen legally not really as a minor, she's 18, but like with the whole thing of her being brought in by the mother, etc., we needed to actually still practice confidentiality, of which I did offer to the patient that I can assist her in sharing the news with the mother if it is that she wants the mother to know. And it was important for me to actually start there with the patient, because when we initially started seeing the patient, I reassured the patient many times that she needs to be as open as possible with all the information that we need from her, as it would assist in the management of the lesions that she was presenting with. And so with that, we try to establish trust, and it's important to maintain also that trust. And so we need to go back to ethics as well as confidentiality and consent. And the age of consent has changed from back then, and so we need to familiarize ourselves with that. And then in terms of management, I know that we all come from or we're working in different settings. You might not be in a hospital, you might be working in private practice, but you can still liaise with a medical practitioner that can actually assist with the management of the patient, but you still have the obligation to follow up on that patient. These are my references. Thank you.
Right. Thank you very much, Bongi. That was a very enthusiastic presentation, a marathon. I have quite a few questions from the audience, but I want to start off by just asking yourself, being present at WITS in the oral medicine department for quite some time and doing your MSc there, I gather from your last comment in closing that at that time you didn't see any cases of syphilis in that department, for instance.
Yes. So, yeah, I had not seen a case of syphilis at WITS, yeah. Yeah.
So the numbers 25,500 per year is seen. So one wonders how many of these patients actually do get oral lesions and how many just go undetected.
Yes.
So that brings us to the first question from, oh, I'm not going to mention names. I think it might make people uneasy. So I'll just ask the questions. So the first question was, what was your thought process to test for syphilis immediately and not consider something like a carcinoma?
Okay, so when we were looking at the presentation, so when we look at the palate, it was that typical mucus patch, but it was mucus patches that were coalescing or fusing to form that snail. Also, the tongue, the patient was presenting with these papillary nodules that would, that are similar to condyloma lata. So maybe just to be honest as well. So what happens in the oral med clinic, yes, I'm telling on the registrars now, we do bring in our oral path and oral med textbook because that helps. In many instances where we need to actually, like I said, with syphilis, the knowledge was back then undergrad. And so, like when we saw those lesions, but then now we're looking at the patient's age and we're also looking at the history that she's not sexually active. Like we had to actually page through and we saw these lesions were similar. And so we did not think of OSCC as well, like squamous cell carcinoma at all. Unmute.
Okay, thanks, Bongi. I just also want to add something with regard to that. It might not be possible. I've never seen a syphilis case in my practice or as a registrar or undergrad. But one of the things that one would look at is the distribution of the lesions. If you have many lesions with a patient that has lesions on the cheeks, on the lips, on the tongue, the chance that it's a carcinoma is not that good. Whereas if you have something that involves the whole mouth in numerous sites, then you need to think of something that's attacking the system. So, but then also the thoroughness or the way that the patient was worked up with a biopsy, that would also give that or attend to that part of the diagnosis. Then another question. Question is, can a patient present with a tertiary syphilis with no history of presenting with the primary or secondary at any stage?
Okay, so what I had read is that, so now, remember, maybe the first question that Dr. Lochner asked me is if I had seen syphilis in at vets. And one of the things is, no, I had not, and maybe many people have not. But there's a lot of patients that actually do suffer from STIs, but they go unnoticed because of the presentation, especially of syphilis, that painless ulcer, etc. So, so when you're looking at the presentation, many of these patients can actually go unnoticed. So they go through the primary stage, the secondary stage, and then remembering that there's also that spontaneous resolution, even without treatment, of your primary stage and your secondary stage, and then going through to the tertiary stage. So there are patients that might not present with, like to your facility or your clinic with primary and secondary stage, but present with tertiary stage, of which it's a gamma or those lobulations that you can see on the tongue.
Yeah, it also depends on the grade of infection that the patient has. We all know that we all respond differently to infections, and somebody, the immune system might actually be quite strong, and therefore the presentation might be shielded, and they could theoretically present at a later stage with no previous history. So there's a question, there's quite a few questions, so I'm just going to go through all of them. If we've got time, it seems we've got time until 8:30, so there's a lot of question time. Wow. I'm sure you've got a lot of water there. So there was a question about what about the partner? What about the whole issue with it turning up with being a sexually transmitted disease? So how did you guys deal with that?
All right. So I did inform the patient. So part of the education that was done is informing the patient what syphilis is, that it's a sexually transmitted infection, and that she needs to get treated, and the partner as well. And also putting in, the whole picture of there might be other people involved as well that will need treatment. And so we cannot, we cannot actually force a patient to bring in their partner, but we did offer that the partner can come in and we screen the partner and assist with the management. So that was declined, that offer was not taken up by the patient, but we did go through the importance of the partner getting tested and getting managed for syphilis. That otherwise the patient, our patient that was presenting to us would not, even with treatment, would not see resolution of their lesions. And also highlighting that she needs to refrain from sexual contact.
Okay, thank you. There was a question about the figures that was mentioned. Maybe I can just clarify that. Dr. Mahlangu, you pointed out that 7.5 million infections in South Africa, but that is new infections of sexually transmitted diseases, and with the syphilis, the value was about 25,500. Yeah, so I just want to clarify that. Then another attendee's got a question about consent. He said, you mentioned that the age of consent for medical and surgical treatment is about 12 years of age with the new legislation. And does this also apply to patients that wants dental treatment, for instance, a consultation, extraction, or a filling?
Okay. Yeah. So the I did.
All right, I think we're hanging there for a moment. I'm not sure if I'm still online. I think we just give it a time for the platform to refresh. I'm going to stop my video.
Oh.
Okay.
Okay.
If I think everything's switched off there for a second, Bongi, maybe you should just answer that question again. I didn't get the answer. I'm not sure if anybody else did. The connection seems to be poor. Can any of the other panelists just give an indication if they can hear anything at this stage?
Hi, Dr. Lochner, I can hear you. It seems that Dr. Mahlangu is struggling with her connection. Dr. Mahlangu, if you can hear us, maybe just switch off your video. That might improve your connection.
Okay, if she can hear us. Otherwise, I'll just make contact with her with a different method to see if we can just get the answers.
While we're waiting to get Dr. Mahlangu online, we maybe just want to thank again our trade partner this evening, Colgate Miradol, and Tip, if you can maybe just place that ad while we're waiting to get Dr. Mahlangu back online.
Hello.
Gum problems? Neglecting your gums can start a chain reaction leading to serious problems. Miradol. The Swiss gum expert helps fight the cause of gum problems, so they don't get worse. Miradol. Healthy gums, healthy teeth. exclusively available in pharmacies.
Right, let's see if we can get Dr. Mahlangu
Yes.
online again. Hopefully she's got a better connection now.
Yeah, I think.
Okay.
Yes.
So some more questions. Maybe can you just re-answer that question about the age of consent? I'm not sure if it was only me that didn't get the answer, or maybe some others. So maybe just answer quickly again.
Can you just repeat that? Because I was losing you there. Like I didn't hear the question.
Okay, I'm also going to stop my video and just go with sound. So the question was, thank you for your wonderful presentation. So that's obviously nice. So they say that for the age of consent, as you mentioned, it is 12 years. Does this apply for patients seeking normal dental treatment like consultations and extractions and fillings?
Does it apply to patients' fillings?
Does it apply to patients seeking normal dental treatment, for instance, if they want an extraction or a filling, for instance?
Yes, because it says consent to management is 12 years. So it does, so, you know, like when you're looking at that, it doesn't exclude any form of management.
Okay,
so my answer would be yes for that.
Okay. Okay, 100%. It looks like that's all the questions. And just a couple of mentions there in the Q&A part are complimenting you with the lecture, and delegates thanking you for that. They've learned a lot and things like that. So thank you very much, Dr. Mahlangu. Dr. Patter, I think it's over to you then for the final comments.
Thank you very much, Dr. Lochner. From SADA's side, we just want to thank Dr. Mahlangu for the lecture this evening. We appreciate your input. Dr. Lochner, thank you to Saspio and yourself for also being a panelist and joining us this evening. As stated earlier, I also want to thank Colgate Meridol, who is our trade partner for the SADA Oral Health Month, who sponsored this evening as well. I just want to remind everybody, once we actually close the webinar and Zoom is closed, please look in your web browser. There will be a pop-up for a survey that we want you to complete. Please remember to do that first. And then also we have a lucky draw this evening sponsored by Colgate as well. Dr. Mahlangu, if you are online, we have, I think, 531 attendees that registered for this event. If you can just give me a number anywhere between number 1 and 531, please.
120.
120. I just want to check on my list who that is. You'll bear with me a second, right? Raymond Aker, right? Raymond Aker, SADA will contact you. You have won this evening's lucky draw sponsored by Colgate. We will make sure that your prize gets sent through to you. Again, just thank you for all the panelists this evening, and then please remember to complete your survey once the webinar is closed. Thank you so much, everybody, and good night.
Thank you.
Gum problems? Neglecting your gums can start a chain reaction leading to serious problems. Meridol. The Swiss gum expert helps fight the cause of gum problems, so they don't get worse. Meridol. Healthy gums, healthy teeth. Exclusively available in pharmacies.